Hello, I'm Janice Karen, Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you go ahead and go to the first update, please. So the first update is an important update. Late last Friday, ONC released the USCDI version 4 draft. This is just basically a preliminary review of what's in it. There's one new data class called facility information that has 3 data elements. And there are also 17 other new data elements that have been added to existing data classes. A lot of the additions are under laboratory data, but there's also several new assessments and bits and pieces throughout, as we'll see as we move forward. The draft is open for comment until the end of day on April 17th. And by end of day, I actually mean 11:59 p.m., not 5 p.m. Comments can be made online on the ONC website. It looks like this time that is the only way they're accepting comments, but you can comment on specific elements or on the draft as a whole. So let's take a look at the new elements they added. So the first thing they added under allergies and intolerances was substance non-medication. For those of you who've been present for some of our previous USCDI discussions, this is a good addition because we were wondering how we were supposed to represent non-medical allergies and intolerances. And the answer is that they apparently did not represent that in the previous USCDI. And this is the mechanism for doing that now. So for encounters, they've added an identifier. Presumably this is basically the equivalent of being able to or required to reference the encounter object if you're using FHIR. So this is also, but if you're not using FHIR, still having some identifier that says this is the encounter that this information is related to. For the new data class, facility information, the 3 fields that they have are name, type, and again, identifier. This is again, probably with an eye towards using this in the FHIR world, where that's probably a separate resource that needs to be referenced from within the facility from within something else. Any questions so far? All right, let's move on to the next slide and take a look at some more of the new elements. So they added 2 new goals, treatment intervention preference and care experience preference. And we will certainly delve into these a lot more when we do a deeper dive into USCDI version 4 for DGC members in the main portion of a later meeting. But these are meant to be the first forays into patient data that's part of this. So these are patient preferences that get recorded and are considered part of the record that are supposed to be come from the patient and not from the provider themselves. So it is, we'll talk about that some more and look at more at how they're anticipating that working when we do the deeper dive into USCDI 4 draft. There are 3 new assessments: substance use, alcohol use, and physical activity. At this point in time, no data on any specifics. If there is any, they tend not to do a lot of specific requirements, but leave these fairly open. So they may do that as well. And then moving into laboratory, as you can see, they've added quite a bit of additional laboratory information. In particular, they've added a lot of specimen specific and result specific. I was amused to see the unit of measure. That's something that we spent a lot of time discussing in our spec work, and something that is definitely appropriate. Any comments, thoughts, questions here? All right, then let's move on to the next page. So there's finally 4 more new data elements. In medication, instructions and adherence. And again, I believe adherence is not some formal program, but supposed to be patient-provided information. They've added a time of procedure to procedures and one new vital sign, which is average blood pressure. And again, we'll get into some of the rationale and some of the details of this later on when we do the deeper dive in the main meeting for those of you who are attending the meeting, the full meetings. So in addition to the draft itself, as they've had the last several times, they've released a standards bulletin, and that standards bulletin has commentary about the changes. So when we dig deeper into these, we'll take a part of what we'll look at is the rationale and what they say in the commentary about why these changes were made or why things were added or how they expect things to be used. And so a lot of our information will come from that bulletin, at least as a starting point. They also usually have a blog post where they talk about some of the rationale and highlight some of the things that they think are particularly important. They have not done that yet. I suspect that's still coming. Again, this came out literally at like 4:48 or something like that on Friday. So there's still probably a lot of work going on in terms of the rollout. But for now, you can find the draft at that URL and the bulletin I referenced at that second URL. Any comments, thoughts, questions about what we know so far about USCDI version 4 draft? All right, well, as you know, we'll get into that in a lot more detail later. Moving on. ONC also released the 2023 edition of the ISA reference last week. That stands for Interoperability Standards Advisory. And for those of you who may not remember, this is basically a long document where ONC collates together all of the standards that they've approved for use for various purposes and basically gives you one place to look for all of the relevant standards for just about anything you could wish to use. So some of the stuff that they've changed this year, one of the big things they did is they added SFAP information. That's the process that they've been using for optionally allowing standards to advance beyond what's in regulation. So for instance, at the current time, USCDI version 2 has been approved via SVAP and can be optionally used instead of USCDI version 1 in those regulations that specify USCDI version 1. So that type of information is now part of this reference. They've also consolidated all of the pharmacy information together and created a new section called Pharmacy Interoperability. That also includes some updates to NCPDP standards. That's, I don't remember what the acronym stands for, but that's the organization that oversees a lot of the pharmacy standards. Excuse me. So that's all together in one place, and you don't have to go hunting in separate spots for that. They've also added a new human and social services section for standards related to referrals to non-medical services. That is something that's been coming up more and more lately, so it's not surprising, and there's a lot of work in this area ongoing in different places, so I would expect that to expand. There's also a new adverse event reporting section tucked in under the public health section. It's not, we'll have to look at that some more and see what's there, but that's been added. That's something we've talked about at the DGC before, so good to see that. They've also added some more laboratory standards and reorganized the related listings for laboratory to make them easier to locate and collate together. And then finally, they added a new infrastructure subsection, which is meant to hold things like emerging standards from FAST, which used to be part of ONC, but is now a FHIR accelerator that works on overarching infrastructure issues. So this is not for standards to be used for a specific purpose, but for things like identity and security that affect everything. So you can find the file at that link. I have not had a chance to look at it in detail yet, so it's possible that we'll bring it back to the group if anything else interesting shows up, but mainly it's meant to be a reference that you can look at as needed throughout the year. Any comments or questions there? All right, moving on. One last ONC bit before we go. I think the next one's CMS actually. So ONC did some sort of further study on someone else's survey about patient access. So this Health Information National Trend Survey using 2019 and 2020 data, and they took that and looked at it with equity in mind. It was focused on portal access, not API or any other mechanism for patient access of data. And one thing that it did not do, which I was a little bit disappointed in since it was looking at access and equity, was it did not address or mention any of the accessibility issues with patient portals or how they impact access. It was solely focused on race. So they did find clear racial disparities, and they highlighted two of them in particular. As you can see from the screen, there was a noticeable difference between the rates that people were offered access to portals and the rates at which people actually access portals. You'll note that they only looked at white, Black, and Hispanic patients. So there's no indication of people who identify as other races where they fall on the spectrum. That's often interesting because there are some areas where, in particular, if you look at Asian patients, for some measures, they tend to do better than any other race, and in some measures they do worse, and they tend to be at one extreme or the other, although that is an oversimplification, and that may not be true in all cases. So they did not identify or look at that, and I don't know if that's because data wasn't available or if that they were particularly focused on the two groups that do tend to most often show negative disparities. So, and you can find the blog post there. Any comments, questions, thoughts there?
Janice, this is Vijay.
Hi, Vijay.
Hi. When it says VAR offered portal access, what does that mean? Does that mean that there was some kind of a restriction where they said only so many people are allowed? And what does it mean by VAR offered?
I'm sorry, I didn't mean to interrupt you.
Sometimes a portal is open to anybody's access, right? As long as they have authorization, authentication, they can get in and look at their information. So is there some difficulties there, or what is the reason?
Yeah, so they didn't specify, but the way that what my assumption and the way that I read it was that when they say offered access, they mean did some type of outreach specifically suggesting. For instance, sometimes when you go visit a provider, they ask you if you're on the portal, and if not, they offer to sign you up. Okay. Or sometimes they'll send out emails to patients. There are email campaigns to patients saying, if you aren't on the portal, or sometimes if they know you're a patient and you're not on the portal, did you know that portal access is available? You can sign up here. So what I took that to be was that they were actively offered the chance to use the portal, or they were educated about the opportunity to use the portal in some fashion. I don't know that for certain because they did not specify.
Thanks, Janice.
Anyone else have any thoughts or questions there? All right, so let's move on. Excuse me. All right, so CMS, you may remember that part of the Inflation Reduction Act that passed last year was Medicare drug price negotiation. That was going to sort of tier in over a very slow period of time. So CMS has announced the timeline for the way that those negotiations are going to happen. So they are currently starting last week, I think, through the spring of this year, doing some public engagement and initial activities in identifying the first 10 drugs that will be negotiated. And then at some point in the spring, they're going to put out some draft guidance on what that process is going to be and solicit public feedback. They'll publish final guidance on what the negotiation process will be in the summer. And then in October, there will be a formal selection of the first 10 drugs. And so those, although they're announcing the drugs this year, the negotiated prices will take effect in 2026. And then next year, there'll be a process of the actual negotiation process. And then basically there's going to be an annual thing every year where during one year, they're negotiating prices for additional drugs for the following cycle. So in September 1st, 2024, there'll be a public release of negotiated prices for 2026. And then presumably September of 2025, you'll get the 15 drugs for 2027, et cetera, moving forward. And it's 10 for the first year for 2020, for next year's negotiation going into effect in 2026, 15 for the 2 years after that, and then every year after that, 20 new drugs. It's not clear if this will have any direct data impacts or not, or exactly whether, how much impact this will have other than, affecting the prices that get paid by the patient and how that interacts with what the payer is responsible for. But I thought it was notable to at least keep an eye on and see. Any comments, thoughts, questions there?
Only that it's very slow. It's going to take a long time.
It certainly is. But I guess it's a start.
Well, it would seem to me to have an unintended consequence of reducing the drugs that are scheduled to be reduced, but pharmaceutical manufacturers raising the prices of others to compensate for those differences. So we'll see how it pans out and what kind of enforcement mechanisms there are.
Yeah, I know that at least what they were eyeing initially, and obviously we don't know how this is going to work out, but they were hoping to overcome some of that by picking a combination of popular and expensive drugs. So I don't mean popular in the sense of well-liked, but popular in the sense of frequently used. And so if the drugs that they choose are a good combination of used by a lot of people and on the more expensive side, there's a little bit less opportunity, although again, they could still jack up the prices of less commonly used drugs by a lot more, which will of course be terrible for the people that it affects, albeit affecting fewer people. So we will, there's no way to get around that entirely. But so we'll have, as you say, we'll have to see what happens. Anyone else? All right, moving on. So this was interesting. Oops, if you go back one day. Nature published sort of a review of several studies on reproducibility in AI with a little bit of a healthcare focus, but not entirely healthcare. So one of the things that they point out is that key to any scientific study is that the results be reproducible, and that's true for anything, but it's also true for AI and machine learning results. And one of the things that we're starting to find is that this is a real problem with AI. And they highlighted 3 studies in particular from very prestigious universities, as you see. So Harvard Medical School looked at there was a competition for AI in cancer care. And so the top 10 performing algorithms within the competition, 5 of which were scored at 90% accuracy or better. This was lung cancer based on CT scan images. Within the competition, they got a 90% accuracy rating. But the single best result that they got when they were looking at it with a slightly reduced on actually some of the same data that was used in the competition, but less of it, was they only got a 60 to 70% range accuracy on the best one. And most of those top 10 scored about 50-50, meaning that it was even guess as to whether it would get it right or not. So that was pretty discouraging. And then a Princeton study that looked more generally at AI results found 300 29 studies that they looked at failed the test. What they did not do in this article, which was annoying, was tell us how many passed. So we don't know if that's 329 failures out of 400, which would be dreadful, or 329 failures out of 4,000, which would not be great, but would be significantly better. Obviously, you don't want 329 things to fail that are presumably being used. And another one, which was very discouraging, was that there was an Oxford study that looked at 62 studies that were using AI to diagnose COVID, and they found none of them were at a level of confidence that they could be deployed clinically for diagnosis or prediction. So all of the AI does poorly, but the study found that healthcare AI tends to do worse than AI in other areas. You can read more about it at this article, but it was a pretty depressing view of the state of AI, and also for lack of a better way of phrasing it, the way that we're publishing AI and the way that we're accepting results and allowing it. I know when I was in school, for those of you who don't know, I studied physics in school. Part of the requirement for getting published and part of the requirement for being able to publish and showing that your results were accurate was reproducibility, and that you got the same results repeatedly when you tried to do the same thing. Obviously, there were some preliminary things that got published that were novel results that didn't meet that grade, but that was also well known. And so the fact that all of this AI is going out and getting published and getting accepted as published, and then further studying into them is showing that a large portion of it, if it is at least having some issues with reproducibility, is an interesting statement on the state of the way that we're doing research right now. So that's my soapbox. I'll get off the soapbox. Does anyone else want to comment?
Well, I think, Janice, this is Danny. I think the articles in the business press and in the industry press that we read about AI being everywhere and how powerful it is and how important it is need to be taken with a considerable, more than a few grains of salt. There are certain things like robotic process automation that aren't really AI, but are, a form of automation where the benefits are real. But as we get into more of these probabilistic AI tools and methods, we're looking at, as you point out in the first hyphen there, this is not much better than a coin toss. So we have further to go. It's an important technology, but we have a lot further to go than the press and the technology vendors might lead us to think.
Yep, definitely so. Anyone else want to comment? All right, let's go on to, I believe this is the last one. This also is kind of a, not to end on downers, but kind of a comment about the way people are reporting on information. Managed Healthcare put out a state of the industry survey, and they published their results, and they published them as serious results. And although they said it was close, they didn't comment at all on the fact that, basically they published survey results where everyone said that everything was equal. So there were 10 issues that they presented to respondents, and they were asked to rate them from 1 to 10 in terms of how important they were. And everything got between 6.27 and 6.73 averaged out between all of the respondents. So, what was the point? And as you can see, I'm not going to go into detail. Interoperability actually scored last. But again, from my perspective, maybe there is some subtle meaning in those differences depending on how many results there were, which they did not specify. But those results are so close that why are we even talking about it? Why are they reporting on this? So the point of the slide was not so much that interoperability scored last or what the results were. But again, a sort of a commentary on what people talk about or what we hear about, because the top line of this survey was that labor shortages and equity and disparities were the top rated things. Well, sure, they were, but what does that mean here? Anyone else want to comment or tell me I'm being crazy or whatever?
No, I'm sure the standard error is probably, more than 1 point or 1 point plus. So having there be, a half a point difference between the lowest and the highest basically says they're all the same. It's also that they're not really parallel. Closing disparities is an aspirational goal. Labor shortages, provider shortages, supply chain issues. The others are kind of industry constraints. Interoperability is like a means to, it's unfortunately an 8-syllable word, which probably didn't help it any. But they're just, it looks like it was kind of a grab bag of, of problems, challenges, aspirations, infrastructure. It's a little bit of a mishmash of different issues as they describe them. So, I can see them being very difficult, if not meaningless, to compare them. And the results seem to support that.
Yep. No, as agreed. And so I guess the takeaway from this, from my perspective, not that I already didn't have this opinion, but I just wanted to put out there, it seems like it's sort of being pushed in our faces at the moment, that people are not necessarily good at interpreting data, and that you need to pay attention to not just the top line takeaways, but how they were determined, to figure out if you want to accept them or if they make sense. Anyone else want to comment on any of this? All right, well, moving on, I believe if that was the last update. If you'll pause there for a moment, Jenny. I hope that you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at the email address on the screen, dgc@myhealthdata.org. Thank you very much, and we hope to see you again next week.